So are you? So Dr. Hassan Salah has been busy with this meeting for the last 7 months. He is still busy with it. So thank you very much. Apparently, I'm the only one. No, I see Hamid wearing his mask. So it's really, and Dr. Jama, thank you very much for wearing your mask. I've just taken mine off, but please do keep it. Thank you very much. So, Assalamu alaikum, rahmatullahi wa barakatuh. Good afternoon, and bon après-midi for those who are French speaking. It gives me a great honor to open this meeting in your presence. Let me start by saying, build the world we want, a healthy future for all. This is the theme of the Universal Health Coverage Day 2022 that we are celebrating today in all your presence. It is a very special day because it's highlighting one of the key rights of every human being on earth to access their needed health services in good quality and with financial protection. The day has been celebrated as the International Universal Health Coverage Day since the year 2017. And the date of December 12th has been selected not because it is my birthday, which is not, but because it is the day when a UN General Assembly landmark resolution was endorsed to enforce and to emphasize the importance of universal health coverage. So that resolution was endorsed in 2012 on December 12th, but it is since December 2017 that we started celebrating the Universal Health Coverage Day. The resolution is urging all member states, regardless of their income, low, middle, or high, regardless of their level of development, to ensure that they are progressing towards the goal of universal health coverage. Universal health coverage simply means that everyone, everywhere, should have access to their needed health services in good quality and with financial protection. To mark the Universal Health Coverage Day 2022 and also to celebrate the possibility that we all come together, we are organizing these 5 days to come together to share experiences, to share with you as well the work that we have been doing over the last 3 years with regard to how to rebuild our health systems moving forward. This is the first meeting that is coming after the endorsement of what I estimate as a landmark regional committee paper that was endorsed in October this year, so 10 years after a previous seminal paper that was led by my former director, Dr. Samin Siddiqui, who is with us in the room, on strengthening the health systems in the region. It is now my honor to invite our regional director, Dr. Ahmed Al-Mandari, to give his opening remarks and to open the meeting. Dr. Mandari was very keen to be with us. He's unfortunately not feeling well, but despite that, he's very keen, and he was very keen to be with us and to share his wisdom and to share some directions for us for the coming 5 days. So Dr. Mandari, if you can hear me, we will hand it over to you.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, colleagues. Thank you very much, Awad, for leading this sort of important event in Emro and WHO in general on this important week, and particularly when it comes into the universal health coverage. As you have said, I was planning to join you, in fact, but because of some health issues, I couldn't make it. I'm wishing you all the best, and I'd like also to thank all colleagues who have come, from different parts of the world, participating us with the session, on this important topic and subject. Distinguished colleagues, ladies and gentlemen, it gives me great pleasure to welcome you all and to celebrate Universal Health Coverage Day with this year's theme, Building a World We Want, a Healthy Future for All, reminds us of our commitment to accelerate progress towards universal health coverage. Today is an opportunity to help meet the commitment by advocating for the critical role of primary healthcare and the health security in achieving the universal health coverage. Ladies and gentlemen, in 2015, all member states of our region committed to achieving universal health coverage as part of the 2030 agenda for Sustainable Development Goal. They reaffirmed that commitment in 2018 by signing the Universal Health Coverage 2030 Global Compact and endorsing the Salalah Declaration on Universal Health Coverage and the Asitana Declaration on Primary Health Care. Universal health coverage means that all individuals and communities receive the quality health services they need without suffering financial hardship. This is only possible by reorienting health systems towards primary health care. The COVID-19 pandemic demonstrated the vulnerability of health, social protection, and economic systems. Efforts to build resilient health systems in our region face many challenges. Half of our countries in the Eastern Mediterranean region are experiencing protracted conflicts and humanitarian crisis. 8 of them have reported outbreaks of cholera and acute watery diarrhea. Extreme climate events, like the floods in Pakistan and drought in the Horn of Africa, are leading to acute hunger and health crisis. Despite these challenges, progress is possible. During this meeting, we will learn about Afghanistan's efforts to expand universal health coverage and protect people from health emergencies, and Egypt's experience in implementing a universal health insurance system as a middle-income country. At the World Health Summit 2 months ago, WHO's Director General, Dr. Tedros, called for a paradigm shift towards promoting health and preventing disease. As he put it, to create healthy societies, we need to invest in a radical reorientation of our health systems towards primary health care. Health is a fundamental human right and requires action at all levels of society, in our homes, our streets, our schools, and our workplaces. As WHO's vision for the region recognizes, the future we all want is health for all by all. Reorienting our health systems towards primary health care will enable everyone to take ownership of health. Engaging in multi-sectoral action, ensuring active and dynamic community engagement and empowerment, increasing equitable access to quality health services, and strengthening essential public health functions. This requires more and better resources for primary health care. Placing people at the center in financing primary health care means that public health resources or public resources are the main source of primary health care funding. Resources are allocated equitably, and provider payment mechanisms create an environment that fosters people-centered quality care without causing financial hardship. In October this year, and in line with our regional vision, the WHO Regional Committee endorsed several regional priorities and related actions to advance universal health coverage and ensure health security. This week, we will discuss strategic actions to reshape our health systems, place health higher on government agendas, and increase financial investment in health and well-being. I am also pleased to announce that we are establishing a primary healthcare regional forum for universal health coverage and health security, as well as technical working groups to share experiences, support mutual learning, and mobilize support. In addition to the above efforts, distinguished representatives from regional and country-level entities will sign a call for action to signal their intent to adapt the regional professional diploma in family medicine, which is essential to provide professional development in the region. Your Excellencies, ladies and gentlemen, thank you all for joining us on this important occasion. Thank you for your efforts. Thank you for your engagement. Thank you for your support. Together, we can renew our commitment to achieving universal health coverage and health security with primary health care at its core, and develop an implementation agenda to make universal health coverage happen in the region. Together, we can build the world we want, a world where healthy people enjoying living in countries with strong, resilient, people-centered, and primary healthcare-oriented systems. Let us work together to make primary healthcare everyone's business. Thank you very much, colleagues, and Jazakumullah khair, and I wish you a fruitful discussion and successful meeting. Back to you, Aw. Jazakumullah khair.
Thank you very much. Thank you very much, Dr. Mandari. I don't know if you can see the room, but we have very wonderful group of colleagues who have been gathering for celebrating this Universal Health Coverage Day. And thank you very much for your leadership, for reminding us of the past, of the present, and of the future. Colleagues, oftentimes we confuse universal health coverage with health system strengthening. And in many places, we limit the work on universal health coverage to health system departments, whether in WHO or in other area. We agree that strengthening health systems is a requirement for enhancing and progressing towards universal health coverage. However, we also believe that universal health coverage is everybody's business. Everyone, all the programs, all technical areas should be working together to advance the agenda of universal health coverage. Somebody once said to me that the litmus test for universal health coverage is to see whether a simple person living in a hard-to-reach area is able to receive the care that she or he needs in good quality and with financial protection. This is how we have been perceiving universal health coverage in the Eastern Mediterranean region. So it's not the business of anyone, it is the business of everyone. And we are really pleased and honored that under the leadership of our Director of Program Management, Dr. Rana Hajji, we have been all coming together as departments to advise countries on how to advance this common agenda of universal health coverage, to help them devising visions, strategies, and roadmaps, but also, as she always emphasized, to move towards implementing those on the ground to advance the agenda of universal health coverage. Now, I would like to invite Dr. Rana Hajji to give us her opening remarks for the meeting.
Thank you very much, Awad. I would like to invite our guest, Dr. Suraya, first, and then I will give my end.
Okay. So let me introduce Dr. Suraya Dalil then. Dr. Suraya, she's the director of the Primary Healthcare Special Program. She's leading the primary healthcare agenda globally. She has been always reminding us, sorry, Dr. Suraya, I'm standing in front of you, reminding us that the approach towards universal health coverage is by strengthening primary healthcare. And these are not only words that she's mentioning, she always practices that. And we've just had a fascinating press conference where she had really provided her wisdom and shared her insights on how really to building and strengthening primary healthcare would advance the agenda of universal health coverage, but would also secure the agenda of health security that we'll be talking about. And also she always add the healthier population, promoting health and well-being. With this, I would like to, and also I tweeted something this morning, I don't know, I'm active on Twitter, so if you would like to follow me, an invitation, that she has chosen our region amongst all the 6 regions of WHO to celebrate the Universal Health Coverage Day. So that's really an honor for us to have you with us, Dr. Suraya.
The honor is mine. Bismillahirrahmanirrahim. Good afternoon. Assalamu alaikum. Thank you very much, DPM Rana Haja, for giving your time to me. And thank you, Dr. Mataria. Distinguished delegates, colleagues, friends, representatives from Ministries of Health, ladies and gentlemen. I'm honored to be with you. Many people say that and they don't mean it, but I truly mean that. Thank you, His Excellency, Regional Director, and the team for having me here. Yesterday, 10th of December, was the anniversary of the Universal Declaration of Human Rights. A declaration adopted by the United Nations General Assembly on the same date, 74 years ago, in 1948. Of the 58 members of the United Nations at the time, 48 voted in favor of this declaration. And several countries in this region voted in favor of the Universal Declaration of Human Rights 74 years ago. It means that this region has a profound history when it comes to human rights diplomacy, and to health in the human rights. So our ancestors did their job. Tomorrow is 12th of December, is the UHC Day that's marked and acknowledged by the health communities and beyond in the last few years. However, there is an intelligent connection between these two dates, 10th and 12th of December, rooted in the fact that health is a fundamental human right. Health as a fundamental human right means that everyone, everywhere, at every age, regardless of their socioeconomic status, gender, ethnicity, location or geography, religion, and political views, deserve to be healthy and to have access to comprehensive, integrated, affordable care when they need it, close to their everyday life. Understanding health as a human right also means that we do not look at the healthcare and health services as a privilege. And I would like to repeat that. Understanding health as a human right also means that we do not look at healthcare and health services as a privilege, something that's only for a specific group of the population, but rather as a duty of leaders to ensure and the responsibility of citizens to demand for it, demand for more and better health care. And very importantly, that means health being part of the social contract between states and citizens. This narrative would mean a paradigm shift in which we look differently at the design of the health system, the distribution of resources, the financing of healthcare, as well as the definition of vulnerabilities and access. In this context, then, the issue of equity becomes of paramount importance. The most fundamental challenge for UHC, arguably in the past, certainly now and in the future, will be distributional. Or in other terms, it's about equity. It's about equity principles, because then it's not just we are falling short of the targets, but rather who is falling short? Where are they and why they are falling short? The equity consideration is absolutely essential because the world we have now is one of a inequitable growth, widening income inequality, rising poverty, and more severely constrained public budgets. Indeed, in addition to the climate change, population displacement, and conflict-related challenges and realities. So it's for sure a call to action to build the world we collectively want. I'm wearing my hat as the director for the special program Primary Health Care, and I would like to say, what I also said in the press conference this afternoon, that the PHC is the enabler, is the equalizer. There is enough scientific evidence and experience around the world and in this region that the PHC is the cornerstone and is the path to universal health coverage. Dear colleagues, what needs to be done? Okay, coming from the big policy and narrative, what we can do as individuals, as experts, as planners, as Ministry of Health officials, as academia, or as physicians, and so on. I think my takeaway or my message to you are 3 I's. The first I is investment. Invest in a health system that's designed, oriented, and operates based on primary healthcare approach. And primary healthcare approach in it has the principles of equity, human rights, solidarity, and communities engagement. The second I is integration. Integrate services in a model that takes health and well-being in its entirety as a whole, because we have seen that the boundaries between being healthy and being sick, between physical health and mental health, between acute and chronic conditions, and between NCDs and communicable diseases are blurred. And the third I is innovation. Policy innovation, service delivery related innovation, digital technology innovation, to name a few. And all the 3 I's, investment, integration, and innovation, for delivering impact. The WHO Director General, Dr. Tedros, laid out 5 strategic priorities for the 5 years for the World Health Organization. One of the strategic priorities that he has envisioned is to radically reorient health systems based towards primary health care as the foundation for universal health coverage. We are therefore, as WHO, committed to move towards this vision and support member states in this journey. That said, next year in September, a high-level meeting on the universal health coverage during the UN General Assembly is planned. Intergovernmental consultation on this is going on. The high-level meeting will be followed by the 5th anniversary of the Declaration of Astana in October next year. The voice and inputs from the Eastern Mediterranean region will be critical in those upcoming events. Partnership is a key strategy in what we do. Our partnership space, guided by the member states and indeed by the governing bodies, include different stakeholders. In particular, the Global Action Plan SDG 3, the PHC Accelerator. We thank you, the region, and the countries for their participation in the work of the PHC Accelerator in the last 2 years. I see many of the representatives who are here have engaged with us in the PHC Accelerator discussions. Thank you very much. Happy UHC Day, ladies and gentlemen. Thank you.
Happy UHC Day to you also, Dr. Soraya. Again, thank you very much for these words of wisdom, reminding us that PHC is an enabler, is an equalizer. These are very strong words. It is the foundation for progressing and advancing universal health coverage. And it is the basis for the integration, the 3 I's that you mentioned, and you add to them an additional I. You refer to investing and integrating, innovating, but also looking at the impact of all of this coming together. And thank you for leading the agenda of working towards reorienting our health systems globally and hopefully in our region on the principles and the values of primary health care. Now, I will reintroduce probably my director, our director of program management, Dr. Rana Haji. And I have mentioned a lot of good things, but the most important thing that I could reiterate is the approach that Dr. Haji is taking to bring all departments together under the umbrella of universal health coverage, the umbrella of primary health care, and to see health systems really being the foundation of all different technical programs. So Dr. Haji, the floor is yours.
No, I think I'll take it this time. Thank you very much, Awad. And good afternoon, colleagues. Assalamu alaikum. Ahlan wa sahlan. Welcome to Cairo. It's really amazing. I was just sitting here looking, actually for a minute, I thought I was still in Geneva because so many of the colleagues I just saw. It's like, okay, wait a minute. We were in Geneva for a global management meeting actually last week, and many of the colleagues, was very nice to see everybody after COVID. It's been a while, we haven't had such a big meeting. You know, I was thinking, and as usual, I will go beyond my very nicely written and drafted comments. I'm sure Hassan will not be happy, but it's really, I just have few reflections, and I'm looking here around the room and looking at the cumulative expertise we have in the room. I mean, many of our dear colleagues, many directors, many senior colleagues who really can teach many of us more and literally have written the books on health systems and primary health care. And it's an honor really to have you all here. I know it's not easy to travel these days, so we very much appreciate you come here to Cairo to celebrate with us Universal Health Coverage Day. Same thing, you know, we were all in Geneva last week, more than 300 senior staff, almost all of our WHO country representatives, senior colleagues, etc. And I was just thinking, you know, we have an amazing powerhouse. Literally, we have a powerhouse. And this was just WHO. Today, we have even more colleagues from countries, from academia, experts, and 40 years, more than 40 years after Astana, we are still advocating for primary health care, and we are still talking about things that were signed almost 40 years ago and then re-signed and recommitted in 2018 when Astana conference took place. And then in our region, we had also the Salalah Declaration, another big achievement in the region. So why has it been like this? Why is it taking us so long at a time where the world is moving so quickly? I mean, even in the middle of COVID, things were still happening. I was just thinking, looking at my a bit more hectic than usual schedule the last 3 months. In 3 months, I've been to, to places like, was really lucky to be to the COP27. We've been, tomorrow I will be in Doha celebrating UHC Day during FIFA. Major events happening. Last year we celebrated the Global UHC Day actually at Dubai Expo. These are huge events. The world and our countries have the capacity to put together world-class events, bringing together hundreds, millions of people actually. But meanwhile, more than 44 years later, we are still not able to meet the basic commitments we made for primary health care. So why is that? I mean, that's what I would really like to know. So of course, as Awad mentioned, I'm one of the converts actually to health, the importance of health systems. By training, I'm an infectious disease epidemiologist and physician. I was really focused, very technical. And, Awad and many other colleagues were able to convert me. Why do we need health systems? What did we learn during COVID? What did we learn during COVID? I learned a few things during COVID. I know some of my friends say I'm not always a good listener, but I listened a lot and we learned a lot during COVID. What we learned during COVID is that if we don't have strong health systems, we will never be able to actually be better prepared and respond to the next pandemic. If we don't talk to each other and we don't work together, we will never survive the next pandemic. What we also learned during COVID is we need to listen, not just to each other. We need to listen to what our communities are telling us, what our communities need, and we need to empower them so they demand the primary healthcare we are talking about. We don't have to all sit here. They need to be the ones going up front and demanding from their politicians, from their government officials that they need what exactly Dr. Suraya was mentioning about the basic right of getting healthcare. What we learned during COVID is without health, countries will collapse, societies will collapse, economies will collapse. We never had as better chance as we had during COVID. The world was never as important, as aware of the importance of health, the importance of services, the importance of basic infrastructure, the importance of data. I look at all of you here and I can say the importance of fighting communicable diseases, non-communicable diseases, maternal and child health, the importance of strong systems, whether it's governance, financing, access to medicine, the importance of health workforce, which is one of our really major weaknesses here in the region, and we keep losing more and more. So we learned a lot during COVID, and we need to really capitalize on this momentum and to keep the focus on health. Never forget health. And COVID told us that we need to, without stronger systems and without ensuring very basic delivery. Okay, I must be saying something really bad, so, or I need, but really, because as I mentioned, I am not here to really preach to the choir. I mean, this is the choir here. You know very much what needs to be done. What do we need to do? I am here to support what my colleague, Dr. Suraya, just mentioned, to have a call for action. And I have to say that it's not all bleak. I mean, just in the last 2 months, I've been in Somalia and Syria and Lebanon, and I've been in Kuwait and I've been in UAE, and I've seen like a whole spectrum of things. And I know because we've done it in some countries that it can happen in other countries, but we are not there yet. And to get there, we're gonna need this call to action to be really, I'm not sure the word, maybe operationalized, taf'il we say in Arabic. It has to be operationalized. We need to put our talk, and all this talk, we talk about integration, we need to put it into action. Why can't we have the same primary healthcare services that is delivering already on immunization, but also delivering fully on immunizations, on TB prevention and HIV, as well as NCDs, as well as on maternal and child health in a really fully integrated way with basic services. What we need is really better commitments from all of our governments and all of our partners, really to implement and to have make a stronger case for PHC, like we make a stronger case for having better emergency preparedness and response, because we just finished the press conference. I don't know how many of you had the chance to attend, but to Awad's, probably dissatisfaction initially, all the questions were on, can you tell us about RSV? What about monkeypox? What about, it was all about communicable diseases because they are attractive, not to use another word. They are, they scare people. We need to make a stronger case. We need advocacy to make a stronger case for why PHC is a weak PHC is as scary as having an outbreak of the next outbreak of COVID or of monkeypox or whatever the next scary bug that will be showing up very soon. So I really, I think for this meeting, I will not be here physically the whole meeting. I'll try to join online when I can and will join later in the week. But we really count on you this time to basically tell us how can we better implement all these amazing strategies that we have put in place. Great papers. We had a really great paper last regional committee on resilient health systems, both for improving primary health care in addition to health security. We keep saying it's, as Dr. Tedros says, the two sides of the same coin, but we need to go beyond the slogans this time. We need to go to real action and come up with a concrete recommendations on how to really strengthen primary health care, and we need to commit ourselves. Awad said, Dr. Rana always pushes us for more implementation. I think we need a stronger push towards showing impact, and we need to commit to deliverables that we can all meet. And if we don't meet, it will be a collective failure. But I think for now, it's our duty and our responsibility to all the people who are looking up for us to improve their ability to access some of these basic services, to be able to serve and to be able to be up to to the commitment we made to serve in these roles and so that the people will trust us and for this big responsibility that we were given. So thank you again very much, and I really look forward to the outcomes of this meeting in helping us moving ahead. And hopefully, inshallah, next time we meet, we will have many, many success stories that we will be able to show in another 2 years. Awad, is 2 years enough? Inshallah. Okay, thank you. Thank you very much.
Thank you very much, Dr. Hajji, for these great words of wisdom and guidance that you are giving to the work on primary healthcare, health system strengthening. You refer to universal health coverage and health security. You asked the question why it is not happening, while we have been talking about primary healthcare since 45 years almost. But also the primary healthcare of Al-Ma'ata is different than the primary healthcare of Astana, and the primary healthcare of tomorrow should be different than the primary healthcare of today, based on the lessons that we have been learning from the pandemic. When we were trying with my colleagues to conceptualize this meeting and trying to come up with an agenda for the 5 days and identify the key issues to be discussed and to be raised and to be debated with all of you, we wondered who would be the best to bring in or to give for us a keynote speech to motivate us, but also to set the ground for the 5 days. And we couldn't think better than Professor Kara Hansen, who has been kind enough to join us despite her busy schedule. So Professor Hansen has recently led the Lancet Global Commission on Financing Primary Healthcare. And given my own biases, so I didn't introduce myself properly. My name is Awad Mataria. Dr. Rana and Dr. Suraya were referring to Awad. So I'm Awad Mataria. I'm director of the department. But my basic training is in health economics. So I introduced my bias of health financing and health economics. And we have been really privileged when Professor Hansen accepted our invitation to join us and to share some reflections from this Lancet Global Health Commission on financing primary healthcare. So, Professor Hansen, the floor is yours.
Thank you very much, Awad. slides. So
Super.
there's next.
Okay,
If
great.
it doesn't work, just say.
Okay, thank you so much. It is an enormous privilege to be joining you here today for this very, very important week of work that sits in front of you, and also to be given the privilege of letting you, of cheering you on as you cross the start line for what I know is going to be a very busy week with lots of action. So Awad, quite rightly, highlighted his own bias towards financing. And I thought, because I'm speaking to a crowd that's not a specialist in health financing, I should try to present the argument for why it's so important. And I think there's really two issues. One is that the financing arrangements we use for primary health care can drive systems towards change, towards new models of care. They can support change, or they can actually impede change. So it's actually terribly important to think carefully about the arrangements by which primary health care is financed. And the other is to pick up a theme that came out of our report. We all talk a lot about people-centered PHC, but one of the things that we argue in our report is the need for financing arrangements themselves to place people at the center. So what I'll be doing in this talk is to describe how we can move towards a situation where people are at the center for the arrangements for financing primary health care. So the challenge, I think, is one that's very familiar to all of you, that priority to health is limited, and that political and professional pressures tend to favor hospitals and not primary health care. And what this means is that in practice, insufficient funding is allocated to primary health care. The resources don't actually reach the front line. They get stuck in the plumbing of the health financing system. And then PHC financing, when it reaches the front line, is fragmented, it's inflexible, which leads to inefficiencies. So this leads to some fairly simple messages, really. One is we need to allocate more resources to primary health care. We need to allocate these efficiently and really protect them until they reach that front line of service delivery. And we need to send them through the system in ways that align funding flows and align incentives with the goals of people-centered primary health care. And the core message of our commission was really this, that we need to spend more, but spend better on primary health care. And that's the case I'll make. So the commission was launched just at the very beginning of the pandemic in April 2020, where we began to meet regularly with a set of really inspiring commissioners drawn from different parts of the world and from different areas of expertise. And what we set out to do were these objectives: to present some new evidence on the levels and patterns of global expenditure on primary health care, to analyze the technical and the political economy challenges to advance PHC financing, and then to identify areas and countries that were doing interesting things around improving the arrangements for financing PHC, with the aim of identifying actionable policies that could guide countries and inspire countries to change their health financing systems. So the commission was published in April of this year, and I would direct you, at the end, I'll direct you to the Lancet hub on the commission that contains both the report in a number of different translations and also some of the policy briefs that accompany it. I'm going to start now by giving you a general landscape of what financing for PHC looks like. So the first picture here is how very little governments spend on PHC in many, many countries. So these are figures that are slightly adapted. Our calculations were adapted from the Global Health Expenditure Database figures on government funding for PHC. But they paint a picture of very, very low levels of expenditure, particularly in low and in lower middle income countries. We were very keen not to come up with a new price tag for PHC. We thought there's enough price tags around. So we didn't come up with a threshold spending to achieve reasonable levels of primary health care. But I can assure you that these levels are far, far, far below the levels of government spending that are needed to achieve comprehensive PHC. The second finding was the continued importance of out-of-pocket payments in financing PHC, even in upper middle countries. So even in the column to the very right, which is for upper middle income countries,
out-of-pocket payments account for almost half of all PHC spending. And I think this audience will be very aware of the consequences of spending out of pocket for financial impoverishment and catastrophe. Interestingly, in preparation for this talk, I went back into our data to see what's available for countries in this region. And the data are very sparse. So these are the only countries in the region for which data are published in the Global Health Expenditure Database. So this is 5 countries altogether, where you can see those patterns are very consistent in terms of differences in the levels of spending for low-income countries and lower middle-income countries. And the composition of primary healthcare spending is also very similar. So this region is affected by the same issues of out-of-pocket payment as is the rest of the low and middle-income world. Another finding from the Commission was the high degree of fragmentation of funding for primary healthcare. And that fragmentation arises in multiple dimensions. One is the very low level of government spending and the high levels of out-of-pocket payment that lead to multiple streams of funding arriving at providers. Another source of funding is the high level of external financing of development assistance. And then a third element of this fragmentation is how the money is spent. So certainly in low and lower middle income countries, we find that patients are predominantly spending out of pocket for PHC for medicines, that governments are spending on curative care, and development assistance is being deployed for prevention and promotion programs. So all of this leads to a system that is fragmented and often not aligned in terms of coherent incentives to provide people-centered care. Does this level of spending matter? We would argue absolutely yes. So this is a really simple, but I think rather powerful scatter plot that shows it plots the level of government spending on PHC per capita against the UHC coverage index. So that's not a PHC index, but a lot of that UHC monitoring index is programs that are delivered through primary healthcare platforms. And you can see that more spending gets you more coverage. That I think we couldn't argue about very much. But the other finding I think is really interesting is the high level of variation in outcomes for any given level of spending. So if you draw an imaginary vertical line around $5 per capita, you can see the enormous variation in the coverage that's achieved from countries that are getting 35 to 38% coverage of the index, right through to well over 70%. And when we see that variation, we must ask ourselves, how come some countries are getting so much more for their spending? So that's the other part of our message, that countries do need to spend more because more spending will give more coverage, but we also need to spend better. And the better is exactly these financing arrangements that I'm going to describe. A couple of other quick points. One is how primary healthcare providers are paid. And you can see from these figures here, we looked at the different ways in which public PHC providers receive their resources. And there's a real predominance throughout income levels of input-based budgets or input-based and fee-for-service budgets. It's really quite rare for capitation or blended capitation methods for paying providers to be deployed. And I'll describe a little bit later the argument for that. And the last element then is autonomy. So it is a question here of if you have access to resources, do you have the freedom to deploy them in ways that make sense in your local conditions? And you can see here, this is from a survey that we did of governments and asked how much autonomy providers had over a variety of different elements of organization, and it's really very low. Providers are not able to make many choices in terms of who they hire, how they deploy them, how they get their medicines, and they're also not able to retain funds over years, which gives them some fairly limited ability to plan and deploy their resources effectively. I'm not going to argue that full autonomy is good all the time. I think it raises the question about which autonomies are important for which types of spending. So we organized our commission really around what we call the health financing functions. And it's these three. It's how do you raise or mobilize funding for PHC? And what are the important pooling considerations? How do you get governments to allocate from health budgets towards primary health care? And then how do you shift those resources from pools to frontline providers? What we added to that standard health financing framework was the idea that these arrangements are very strongly rooted in the political and economic and social context of each country. So I'm going to talk a little bit briefly about each one of those. So the first is to recognize the importance of government funding in general. So you'll all be familiar with the sorts of negotiations that go on each year between the Ministry of Finance and the Ministry of Health. And so how much money finds its way to the health budget is the first step in determining how much is available for primary health care. And then within the health budget, there's a further tussle for resources about what should go to hospitals and what should go to primary health care and what should go elsewhere. And so really, in order to really drive change in PHC spending, governments do need to spend more in general. So they need to increase their tax base in order to afford a greater level of government expenditure. They need to spend more on health. And then within that, they need more to allocate to PHC. We do talk also about pooling in the report and the importance of using pooling arrangements to first cover primary health care, not to start with hospitals and work down, but to start with primary health care and work up, because there's lots of evidence about the impoverishing effect of continued exposures to out-of-pocket payments for primary health care, and particularly for chronic conditions. Allocating resources to PHC, it always makes me smile when I say this, because this is the part of the commission that I learned the most about. I think I was quite naive when we started thinking about what it means to allocate resources to PHC. And what I really learned was two things. One is the importance of budgets. So budget formulation and budget execution are absolutely critical part of this story. But the third is also about how service delivery arrangements themselves can help to direct and protect resources for PHC. We went through in the report a number of different innovations happening at the country level to get either centralized or decentralized authorities to allocate more to PHC through program budgeting. South Africa has a program budget for primary health care. There are budget rules or matching rules or conditional grants that can be used to encourage increased investment in PHC. On the budget execution side, we became particularly interested in how provider payment is not just a way of setting incentives for providers, but it's also a way of moving funds towards primary health care and of protecting them. But service delivery is something I think it's also important in these discussions that we're going to be having here about new models of care for primary health care. So we looked at a number of countries that by shaping their service delivery arrangements, were able to pull more resources towards PHC. And I was very excited to hear about the work that's been done here in the region in terms of your new professional diploma in family medicine. It made me think about other countries that through shaping a cadre of family medicine doctors as PHC providers, such as in Estonia or in Turkey, have been able to really give greater prominence and greater resources to primary health care. The last financing function we talked about in the report was about how providers are paid. And we made an argument, kind of a first principles argument, that the very best way to pay providers for PHC is through capitation, so per capita based allocations. Whether that's a per capita formula to regional authorities, or whether it's a per capita payment to actual providers based on the number of patients, a number of people living in their catchment areas, or the number of patients that are registered with their practice. And the reason we felt that capitation was so important was that, first of all, capitation really places people at the center. It starts with an equal allocation per person. So it starts from this principle of equity. Then you're able, with that per capita allocation, to adjust it based on needs, further reinforcing that equity. Capitation is the only payment mechanism that really incentivizes providers to be mindful of prevention and promotion. And capitation also gives providers a predictable and regular source of income, which enables them to plan and manage their services more carefully. So we think that is a really strong argument for capitation. The health economists amongst you will know that every way of paying providers has some limitations. And so, and the limitations of capitation can be that you might have a lack of provider effort. So we argue that as countries move through capitation, it's possible to then bring in additional provider payment mechanisms that help to mitigate some of those weaknesses of capitation. So this is a picture actually from Estonia, which was a real innovator in terms of family practice and the introduction of capitation payment in the as they emerged from the Cold War. And this actually compares the makeup of capitation payments very early on when the system was developed in the early 2000s and how that evolved over time. But you can see that blue bar, which is capitation, remains the predominant form of income for providers, but they also get at your basic capital allowance. They get some things that are paid for by fee for service. They have bonuses for training, and they have some quality-based bonus payments as well. So you're able to, in a coherent way, use that mix of payment systems to get the very best in terms of performance from primary care providers. Now, obviously, countries are at really different places in terms of that journey towards a more strategic approach to provider payment. So we developed this kind of model of how countries might progress towards a more strategic payment system, where on the horizontal axis, you can see this involves a movement from a passive payment system to one that's more strategic. And on the vertical axis, you can see it involves changing the incentives over time from poorly aligned with the objectives of PHC to well aligned with the objectives of PHC. But importantly, underneath that arrow, as you move from the status quo, which might be input-based budgets or fee-for-service, through simple capitation and then more complex forms of capitation and then blending, there are some really important health system functions that underpin that. And so moving at the pace of health system development is really important. The last piece of our puzzle was thinking about the political economy. And here we were very committed to demonstrating how the political and economic and social conditions are as important as any nice technical fixes for the health financing system. So our analysis of political economy involved recognizing the power relations that exist among stakeholder groups in relation to how resources are distributed. Because resource allocation is ultimately a political question. There'll be winners and there will be losers, and it's important to craft alliances that will be able to manage that navigation through the systems of winners and losers. And these political economy factors, they're often easy to see as constraints, right? They're gonna hold back progress. But in countries that made rapid progress towards an increased emphasis on primary health care, there was a real use of the opportunities that presented themselves to drive forward change. And what that meant often was having technical solutions ready to go when the political moment offered itself, and using that awareness of the political situation to navigate and stay on the path, because very often there will be shocks and deviations and setbacks, but having a clear path towards an enhanced financing for PHC seemed to be an important element of staying the course and ensuring continued progress. So to my final messages then, so the mantra of our report was spend better and spend more on primary health care. And we felt that in order to have the ability to drive systems towards a more people-centered PHC, that people also had to be at the center of the health financing arrangements. And we described that in terms of the attributes of health financing arrangements. The first was that public resources need to be at the core of PHC funding. We have to move away from a situation where we have this predominance of out-of-pocket payments and replace that with pooled public funds. The second is that pooling arrangements need to cover PHC first and also include essential medicines. And that's another piece of this puzzle that I don't have time to talk about here. But in both these cases, we have people at the center through contributing to public resources, but also benefiting from pooling arrangements. The third attribute was really about resource allocation and making sure that all of the tools at our disposal, whether that's budget formulation, budget execution, or service design, should be deployed to allocate resources equitably and to protect them until they actually get to frontline providers. And then finally, to think carefully about what are the incentives embodied in the provider payment system, and to move towards a system that has capitation at its core and eventually blending to get to align incentives best towards people-centered primary health care. We had a couple of other recommendations as well. One was the importance of working across government. And that means both working multi-sectorally across ministries and importantly between the Ministry of Health and the Ministry of Finance, but also working downwards through government, particularly in areas of decentralized systems. The second was the need to have a strong political understanding to be able to drive technical solutions. And that means building new alliances with champions and people who are able to navigate the political system. And finally, to revisit how we collect and present and monitor PHC expenditure in order to best help countries increase their funding, increase their commitments, and be held to account for them. So I'd like to close just by thanking my team. We had a fantastic set of commissioners who worked tirelessly for 2 years during the pandemic. And then to direct you, if you're interested, towards the report itself on the Lancet website, or towards our project website at the London School of Hygiene and Tropical Medicine that has a series of other complementary materials. Thank you very much.
Thank you very much. Thank you very much, Professor Hansen, for this wonderful overview of the great work that the Commission has been involved in. And thank you for providing the references for more insights and for more material on the subject. I'm sure that we will have more time to discuss. And on the last day of our program, we will be having another session to discuss mainly the outcomes of this of the commission report. I mean, we'll be very unfortunate that Professor Hansen will not be with us, but we'll have hopefully he will be joining us, Dr. Joe Kutzen, coming from Geneva, and he will be debating many of these messages that we have listened to. But this is just to give you an insights and to set the ground for the whole thing that we'll be doing over the coming five days. With this, I would like to hand it to my dear colleague, Dr. Hassan Salah, who has been the brain and the engine, along with many wonderful colleagues behind the program of the 5 days. He will be moderating the follow of this session. Hassan.